evidence that it's really superior for some patients over TPA, that comes from the last 1.5 years. And this is the therapy that is closest linked to the initial intra-arterial thrombolysis approach. But now it is not a drug that will recanalize the vessel. Now it is a device like that, looks like a net that is put around the thrombus. The thrombus is kind of embraced by this net. Then it's retracted out of the vessel. When you retract it, you bring out a thrombus like that is in the middle of this catching net, and the vessel is open again. This can be done really quickly. It's a sudden recanalization. And we now have, over 18 months, the evidence from 5 randomized trials, each of them statistically significantly superior for thrombectomy. So that is now a treatment of choice for patients with a severe infarct and a very large vessel occlusion with a lot of thrombus inside the vessel. Also here you have to treat early, very early, because also for mechanical recanalization, the time is brain concept is true. It's something that needs expertise. It's not something that can be offered in every small hospital because it also needs an infrastructure with a 24-hour, 7-day-a-week availability of an interventional neuroradiologist. So you have to do that in centers, and currently most people think of 1 center per million, 1 center per 2 million inhabitants, where this could be done useful. It also has to do with expertise. If you are in a center and you do 20 thrombectomies per year, you will never be an expert. The big centers nowadays do 200, 250 cases a year, almost every day a case. And that allows, of course, also for training new people who can do this. So these are the established therapies that we have. Stroke units, useful for all patients, irrespective of age, severity of stroke, gender. And an effect size from 15% better outcome. IV lysis, suitable up to 25–30% of patients. Very much time dependent, effect size 20 to 40%. Thrombectomy, probably for 15% of all stroke patients. Within 6 hours, a big effect size. Hemicraniectomy, an effect size of 80%, but only something that is for a very small subgroup of patients. So that is what we have. And this has changed the 25% rule. 10% nowadays, only 15% are severely handicapped. We halved the number of patients who were dead or severely disabled. Yes, there are a little more patients who survive with a mild handicap. We cannot cure everyone, but we can prevent them to die or to be dependent. And yes, we get 15% more patients into a normal situation. And I will shorten the last part, which is the implementation. We have it. You have it here in Debrecen. It's here. But not in all countries. And in some countries, not in all cities. And in some cities, not in every hospital, of course. And I already mentioned it's only widely available in high-income countries. In Debrecen, the situation here is wonderful. It's an excellent system. I know it for 15 years now, and I've seen it grow, and I've seen it reaching the same standard that we have in most universities, but not all university hospitals in Germany. So it's a wonderful achievement, Laszlo, that you have done here, and your role also internationally is remarkable and extremely important. I can only say this must stay the main topic of Debrecen's neurology. Outside of the high economy countries, the situation is a disaster. 70% of the world population has not access to the simplest approaches for stroke medicine. They don't have neurologists, they don't have trained stroke nurses, they don't have stroke beds, they don't have CT scans. We are talking about buying the 5th MRI scanner. There are countries that have 2 CT scans in total. And think back 25 years ago, when the political situation in Europe changed. In the former German Democratic Republic, at that time, there was 1 MRI scanner, and that was in the capital, and only people who had very close connection got an MRI, okay? At that time, in the city of Heidelberg, we already had 4 in a city of 150,000 inhabitants. So that shows how things have changed, and you will remember how many CT scans you had before 1985, right? 2 in the whole country. So that is what happens in the majority of the world. 20% of the world population will have access to basic elements. There are neurologists. There are the first attempts to create smaller units. And yes, they try to give TPA to some patients. But then it comes to the different reimbursement systems. Those countries with the worst health system have everything available for private paying patients. In India, they will ask the relatives of the acute stroke patient, can you pay for TPA? If they say no, then they send the patient back because they cannot afford to give it to them. And this is true in many, many parts of the world, believe it or not, even nowadays. And then only 10% of the world population has access to what we have. When we implement, we cannot hope that all of a sudden everything changes and everyone is on the same level. Our attempt now is we try to bring the system 1 step or half a step upwards in every part of the world. And that is also true for high-income countries where we have major differences between cities and regions in the high-income countries, but it's specifically true for the low and middle-income countries. And that is the vision of the World Stroke Organization for this year. It is a life free of stroke. It means improving management reality everywhere, stepwise, not all at once. Work on inexpensive basic prevention and management structures, improve knowledge and public awareness, and talk to politicians and healthcare providers of what's coming up to them, what they will face in the next years in the field of NCDs and stroke. And with that, I would like to stop. Thank you very much for your attendance, and I wish you all a life free of stroke. Thank you.